Okay, I'd like to welcome Dr. Buckingham.
Okay, good afternoon. Can everybody hear me okay? Okay, a little bit of a cold, so I sound a little nasally, so let me know if you can't hear what I'm saying, okay? All right. Sure, okay, is that better? Okay, perfect, good. All right, so I'm a movement disorder specialist. I'm with Stanford Health. I've been there almost 10 years now, which is very hard to believe. I practice in Stanford, Wilton, and New Canaan. So today we're talking about a lot of the sort of practical day-to-day factors that we think about with Parkinson's and that are important. Not a lot of talk about medications today. A lot of it is sort of lifestyle. We'll specifically go into sleep and what sleep disorders we often encounter in Parkinson's. We'll look if there's any evidence related to diet. And then at the end, a lot of different sort of lifestyle tips and strategies. Okay. So this will be about 20 minutes, so hopefully about 10 minutes for any questions at the end. So we'll do a brief overview of Parkinson's, which will be very quick because I know we all know what we're going to talk about. We'll specifically go through what are the motor symptoms and then what are the non-motor symptoms that we may encounter. Like I said, sleep disorders and management, diet recommendations, and lifestyle. So as we know, a progressive neurodegenerative disorder primarily characterized by loss of dopamine, but of course we now know there's a lot of other mechanisms involved with the disease state. Age of onset approximately 65 to 75, although about a quarter of patients are diagnosed younger than 65. About 1.1 million people in the US and rising with Parkinson's and about 10 million worldwide. As we know, the only intervention to slow progression is exercise, aerobic exercise, which I'll touch on a few other times throughout the talk. Medications, there's many of them. They are primarily to control symptoms and to help with symptom management. Some common symptoms, of course, are tremor, loss of coordination and dexterity, muscle stiffness, difficulty walking, loss of balance. But there's a lot of other symptoms which we consider non-motor, which are important and can really impact somebody's quality of life. So we'll go through those. So motor symptoms, of course, are physical symptoms. So these are symptoms that you notice physically in your body and that other people often will also observe. So tremor, of course, not everybody has tremor with Parkinson's, but that is a common symptom. Stiffness, which can be arms, legs, neck stiffness, truncal stiffness, slowness of movements, loss of coordination, change in the posture, difficulty walking. Some people get freezing of gait where their feet are sort of stuck to the floor. Their brain knows they want to move forward and their feet aren't cooperating. Changes in balance, changes in voice. Voice is often characterized by a soft voice, a lower volume, although we can also see people who have a voice like a fast speech, like their speech is very quick. Occasionally a little bit slurred, although that's not very common. Some changes in facial expression, trouble swallowing, drooling. So those types of things are, not everybody gets all of these by any means, but they're usually symptoms that other people can notice. Non-motor symptoms, on the other hand, are very, very common, and they often aren't visible to other people, which sometimes means some people don't understand how you're feeling. It also sometimes means that they might not be something you even report to your doctor, but they're very important because they often will really impact somebody's quality of life. Excuse me. So those are things like orthostasis, meaning your blood pressure becomes too low. So that can be often when you change positions, so standing up from a chair, standing up from bed, that type of thing. You can also feel low blood pressure after climbing a flight of stairs or having a big meal, but people will often feel lightheaded or just very, very tired. Constipation is very common, changes in urination. Fatigue, I would say one of the more common ones, multifactorial, difficult to sort of pinpoint in a lot of patients. Changes in mood, so depression, anxiety are very common. Apathy, meaning loss of motivation, not sort of feeling energized, pushed to go out and do things, to socialize with others, that type of thing. Some patients experience hallucinations, cognitive changes, and then changes in sleep disruptions. So these are important to always sort of keep on the radar. Again, not everybody experiences all of these, but as you can imagine, they definitely impact quality of life. So getting into sleep disorders. So it's estimated that at least 80% of patients with Parkinson's experience a sleep disorder at some point. So very, very common. And as we know, poor sleep quality can lead to worsening of motor symptoms. So as an example, you have a night where you really didn't sleep well. The next day you might notice your tremor's worse, your movements are slower, your balance is off, that type of thing. So sleep is, of course, very, very important. We also know poor sleep quality can worsen your mood, so it can contribute to depression, anxiety, and it can also affect cognitive functioning. So the most common sleep disorders in Parkinson's, there's REM sleep behavior disorder, there's insomnia or sleep fragmentation, and then there's restless leg syndrome. So we'll sort of get into all of these. So REM sleep behavior disorder. So I would say the number is probably higher, but at least 50% of patients have this very specific disorder. It often actually will precede your diagnosis. So by the time people are diagnosed, a lot of times they sort of look back in time and say, you know what, remember, actually this usually comes from the spouse or the family, but remember 20 years ago you went through that period where you were really yelling out in your sleep, moving around a lot in your sleep, that type of thing. It often will precede the diagnosis, although not always. And what it really is that you're acting out your dreams. So as you can see, the sleep cycle down there at the bottom, we all naturally will progress through this cycle throughout the night. When you get to the REM, the REM specific portion of the cycle, that's when we dream. So that's when a lot of vivid dreams are happening. Normally, we're paralyzed during that period. So we're dreaming, but our body's completely paralyzed. We can't move, we can't speak. But with REM sleep behavior disorder, there is no paralysis. So those dreams actually start to become acted out. So that could be talking in your sleep, it could be yelling, could be screaming, and it could be moving around, so moving the arms and legs. A common theme with this is people are either dreaming about being in a fight or being chased or something sort of vivid and intense. They're not always like that, but those are really, really common types of dreams. So as you can imagine, there's often a lot of punching, kicking, diving, throwing the hand over to the nightstand, or sometimes affecting your bed partner. So sometimes, patients end up having to sleep alone because they're too active at night. So we always are monitoring for this sleep disorder, of course, to make sure that you're having a quality of sleep, but also for safety concerns. I've had patients who have, dove out of bed, hit their head on the nightstand, right? Or punched their husband or wife, not on purpose. So it's something we're always screening for. And I would say, it's probably a little bit more common than 50%, but it's real and it can affect many things. So that's one. Sleep fragmentation or insomnia is also very common. That's certainly common in the general public as well, but this is difficulty falling asleep or staying asleep or both. And basically it's that your sleep is disrupted. You can't maintain your sleep cycle throughout the night. Parkinson's specifically, some common reasons why this could happen would be urinary frequency, right? So getting up to go to the bathroom every 2 hours. Of course, it's difficult to, have a good sleep in that scenario. Anxiety, sometimes the actual motor symptoms of Parkinson's. So I'd say probably tremor and stiffness would be the two that could disrupt your sleep cycle. And then the other factor, which we're also always screening for, is, throughout the daytime, are you really tired? Are you dozing off and napping all throughout the day? Because then, of course, your body is not going to feel like it really needs a lot of sleep at night. So we don't want patients to have that reverse sleep cycle. So those are sort of the common reasons why you might have this sleep fragmentation or insomnia. And then the other common scenario would be that you have restless leg syndrome affecting sleep or periodic limb movement disorder. So restless leg syndrome can occur, of course, without Parkinson's. So there's many people who have this specific disorder who don't have Parkinson's, but it can occur in Parkinson's as well. And it's characterized by this internal uncomfortable feeling of restlessness that causes you to have an urge to move. So it's not a tingling, it's not a numbness, it's not a burning pain. It's hard for a lot of people to describe it, but it's very uncomfortable. It occurs primarily at nighttime. And the key is that if you're feeling this urge to move and then you move, so either moving your legs in bed or getting up and walking around, you feel relief. And then periodic limb movement disorder is a little bit, I would say, less common, but it's typically while you're sleeping, your legs are moving. So often your bed partner or spouse will notice it the most, but it's sort of like you're sleeping and you're in a deep sleep even, and your legs are moving. Not in a purposeful way like you see with REM sleep behavior disorder where you're actually kicking or cycling your legs. It's just sort of a periodic movement of the legs, which of course can wake you up, can wake your bed partner up. So that's another factor that we're sort of screening for. And then what is the management of these? So very specifically, REM sleep behavior disorder, there's really, for the most part, only 2 treatments. So both are of very strong evidence for helping with REM sleep behavior, and that's melatonin and clonazepam. Typically start with melatonin. The dosing can vary, the timing can vary. We usually try to use that first before jumping to Klonopin, but Klonopin works very, very well as well. Excuse me. Insomnia, we definitely don't jump to medications for this. So part of it is, I put this particular photo there, part of it is sleep hygiene, meaning probably for the general population, right? Don't bring your devices to bed. Don't bring screens to bed. It's going to affect the way that you're able to sleep. So the first thing with generally, right, with having sleep fragmentation is making sure you have good sleep hygiene, addressing any underlying causes for why you're up at night. So that could be urinary frequency. It could also be, like I said earlier, the motor symptoms of Parkinson's, meaning sometimes just taking levodopa at bedtime really helps. So that can help to sort of calm the body down, relieve any stiffness or tremor. So that's sometimes an option. And then other common sleep aids we might use are trazodone, mirtazapine, quetiapine, gabapentin. And then restless leg, periodic limb movement disorder, typically use gabapentin or Lyrica. Again, sometimes levodopa or sometimes dopamine agonists. Okay, so diet and PD. So there's a few different sort of subtopics. So number 1, is there any evidence for a specific diet that could be helpful? I always get the question about diet related to when you dose your levodopa, so we'll go over that. Weight loss, which is also something that we do see, which is common sort of as the disease progresses. Constipation, and then hydration. So in terms of diet, the strongest evidence, which is not really that strong, but sort of the evidence we have the most for, is the MIND diet. So that's essentially a Mediterranean diet, but sort of a combination of the Mediterranean and the DASH diet. And it's been studied for Parkinson's and Alzheimer's. And there is evidence for it for at least potentially, if you don't even have Parkinson's yet, like delaying the onset of the disease, maybe for slowing it down. And I would say there's also some evidence just for aging in general, right? Trying to prevent any cognitive changes from happening as you get older. And it's a primarily plant-based diet, including fish and including good fats, but limiting dairy products, limiting red meat and processed foods. Foods rich in antioxidants, evidence for that just generally for aging. I would say not necessarily specific to Parkinson's, but to help the brain function better and be healthy as you age. So you can see the various foods that are high in antioxidants. And then some more specific scenarios would be where we recommend patients who have frequent orthostasis really should be eating more salt. So that's sort of a specific diet recommendation in that scenario. And then constipation, we'll talk a little bit more about, of course, taking in more fiber. So protein and levodopa. So in general, levodopa, meaning, right, Cinemet, Rytary, Crexant, they work best if you take them on an empty stomach. That's not always possible. You know, if it is possible to sort of arrange your medication schedule so that you take each dose before a meal, so 30 to 60 minutes beforehand, that is ideal, right? If you have side effects to the medication, such as you feel nauseous, you get a little bit dizzy, right? We know that levodopa can also cause orthostasis, so you take a dose and it makes you feel sort of that lightheaded dizziness. Then in some of those cases, you should take it with food to sort of minimize those side effects. Or if your dosing is very frequent, right? So patients who need to take the medication every 2 hours, every 3 hours, it becomes very challenging to try to figure out, you know, when you take it in relation to food. But in general, if you can take the levodopa on an empty stomach, it works best. Reason being is that protein in particular blocks the absorption of the levodopa. So as long as you're taking it on an empty stomach before your meals, I generally say don't worry about the protein. If you're somebody who has to take it with food or your dosing is very frequent, we generally say to limit protein, which can also be difficult though because we don't want to eliminate protein because we need it for other reasons. So it becomes tricky, but I always say if there's any way for you to take it on an empty stomach, it just generally works better that way. And then the only other consideration is iron supplements in particular, or multivitamins that contain iron. They can also block the absorption of levodopa. So just trying to separate that out from doses. Weight loss in Parkinson's, it's always good to keep track of your weight. There's a lot of reasons why patients lose weight. It could be you don't have the same sense of taste and smell. You have a lot of issues with constipation, so your appetite is not strong, or trouble swallowing. Or sometimes patients are eating a lot and they're eating well and they still lose weight, in which case it's probably more related to the actual disease. So just an increased metabolic demand from the disease itself. But it's always good to keep track of it. When it begins to happen, we normally say to see your primary care doctor first, just to be sure there's not a medical cause for it. Most often there's not, and it's the Parkinson's itself. Some people have weight to lose and some people don't, but in general, older people who lose weight start to lose muscle, which we don't want, which then gets back to the protein issue. So it becomes a little bit tricky sometimes, but we do know that making sure you're eating enough protein and enough calories can definitely curb the weight loss and ensure that you're not losing too much muscle. Constipation, also very, very common. And the reasons we want the constipation to be well managed, number one, people just feel better, of course. Constipation, when it is not well managed, it can reduce your appetite. It also actually can reduce the absorption of the levodopa. So if your sort of GI system is not running very well, very slow transit time, the levodopa is also not absorbed that well. So another reason to make sure that you're sort of keeping track of that. Constipation has actually been pretty well studied in Parkinson's because it's so common. So there's some evidence for using Miralax, using probiotics, and using lubiprostone, which I typically don't use, but definitely use the first two. Probiotics, there's research looking at specific strains of probiotics to see if there's certain strains that are more helpful in Parkinson's. That gut-brain connection, this one in particular, there's some evidence for probably helping in Parkinson's. It's the PS128. And then other ways, other sort of helpful hints for constipation, of course, drink enough water, exercise, dietary fiber, and then stool softeners using colace or using magnesium. Those can also help. This is another specific, it's like a natural way to treat constipation, and there's papers published about this. That's how common constipation is in Parkinson's. So I do have some patients who use this, and you can sort of titrate this mixture to try to help with the constipation. Okay, and then last part is lifestyle. So Parkinson's loves consistency, right? Meaning the more regimented and consistent you are with your day-to-day activities, the better the medications work, the better you feel. So one of the more important ones is that medication schedule. So just trying to be very regimented with the time of day you take it. Again, on an empty stomach if possible. But patients definitely do better in the short term, and they do better in the long term if they're really regimented with the medication schedule. Sleep schedule, exercising every day, right? Well-balanced diet, potentially the MIND diet if you can, and then drinking enough water. So honestly, even, right, sort of managing these specific factors and being really consistent with your day-to-day, I mean, it reduces the chances that you're going to need to escalate your medication doses frequently, right? If you're really consistent with these things, it definitely can help sort of reduce your medication burden. So strict schedule, the exercise. I included all these photos of exercise, just meaning, right, in an ideal world, you would do, intense aerobic exercise every day, right? Not everybody can do that, whether it's your age, your orthopedic issues, whatever it is. Any sort of exercise, though, is better than nothing, right? So if what you can do is walk, that's great, right? Ideally, it should be power walking. It should be intervals where you're trying to get your heart rate up, right? If what you're able to do is chair exercises, go to chair exercise class, that's great, right? Any of these things are, there's very, very strong evidence for slowing the progression of disease. And then along the same lines, just generally being active, right? Being an active person. People age better by being very active, and patients do better with Parkinson's over time just by being active, right? Trying to get out of the house, again, exercising, very, very important, but, right, socializing, trying to learn new things. The more your brain and body are stimulated, right, the better you will do over time. Okay. So today, a lot of it was about non-motor symptoms and about some of these symptoms that maybe other people aren't noticing, but you're experiencing that are really affecting quality of life. So things that patients should be sort of monitoring, but we, as your specialist, are always keeping on our radar. And one of the more important things, like I said, screening for all these non-motor symptoms, and then trying to develop a very regimented, no, I shouldn't even say regimented, but a very regular routine that you're in every day, right? So that's your medication schedule, your exercise schedule, sleeping, eating well, getting out of the house, drinking water, all those types of things. Those are my sources for today. I do want to make one plug for, we have a new movement disorder neurologist in our group. She actually just went on maternity leave yesterday. But she'll be back. She'll be back in May. She completed her fellowship at NYU last year, and she's seeing patients in Stanford. and she's excellent. So a quick plug. And then a last reminder that the snow will be gone soon. The warm weather is coming.
Okay, we have time for about 2 to 3 questions. Does anybody have a question for Dr. Buckingham? Thank you, Dr. Buckingham. Yes.
What is Parkinson's disease?
What was it? I'm sorry. What is Parkinson's? Oh, okay. So Parkinson's is it's a brain disorder. So it's when the brain doesn't make enough dopamine, which is a chemical in the brain, which then leads to people not being able to move as well.
Quick question about diet and timing for medications. If for some reason you're talking about on a daily basis having the meds 30 minutes to an hour beforehand, can't always do that for various reasons during the day, activities, whatever you. Question then, if you do eat, how long afterwards can you take your meds, and should you change your time schedule or try to stay within the regular daily system?
That's a good question. So if you are taking a dose after a meal, generally it should be 1 to 2 hours after your meal. It's, in my opinion, I would say it's still more important though to keep your schedule of medication. Unless you're somebody who is, like some patients realize, right, over time, if they took a medication with a full stomach, they don't even feel at work, right? And in that, if you're somebody in that subset, you know, I would try to adhere to the guidelines for meals. But in general, I would say it's more important to be on a time, even if you just ate at that time. I would just still keep the actual timing schedule, if that makes sense.
On the same vein, with respect to the timing, the issue is mostly with protein. So in other words, if I get up in the morning and I want to take my levodopa and I want to drink a fruit smoothie, am I good to go?
Yes. Yep. Right. That's a good point. Yeah, it really is protein specifically. Right. And I would also say I would say also kind of correlates with how much protein, right? If you have a steak and then you take your dose, it's probably not going to be absorbed at all, right? Versus
bacon, egg, and cheese sandwich.
Yes. Right. Versus like a small amount of protein. It's not the end of the world.
One more quick question, anybody? All right.
Any of the Parkinson's drugs that you could take cause the hallucinations, or is it the Parkinson's that causes the hallucinations?
It's usually a combination. That's a good question. You know, the disease itself can cause hallucinations. I would say pretty much all the medications we use could also cause hallucinations. So it's kind of a combination.
Is there any way to figure out which, just by stop taking the medication?
It would depend on the scenario. So certainly if, you know, if hallucinations are, let's say like a certain time of day, right? Like they always happen late afternoon, right? One option would be whatever dose of, let's say the Cinemet that is around the middle of the day, maybe you reduce it and see if the late afternoon is better. So that way you sort of know, like, is the medication contributing? If they're sort of happening randomly or all the time, we often, and they're bothersome, I should say, right? For some people, they're really mild and we don't necessarily do anything about them, but we watch. But, right, if they're severe and they're frequent, we typically use separate medication to treat that.
Would mirtazapine or trazodone cause them?
Not typically. Not often.
Okay, thanks.
Thank you.
Okay, last but certainly not least, Dr. Salvadori from UConn, here to talk about deep brain stimulation and focused ultrasound.
Thank you. Okay. No worries. Thank you. All right. Hello. Can everyone hear me okay? All right. Perfect. So I'm also a movement disorder specialist, and I work out of UConn Health in Farmington. So I love coming down here because first I live close to here, so the drive is not too bad, and I love Ridgefield. So thank you for having me. So today I was asked to talk about deep brain stimulation as well as other surgeries for Parkinson's. And a little bit about the new technology with DBS that just came out, something called adaptive DBS, which is very specific. So just so you know, if you read about it, so you can be informed about it. So I'll talk a little bit about who can have surgery, who might want surgery, who we might not want to have surgery, how to know that, and what questions to ask your doctor. As well as focused ultrasound, which is a type of surgery, but completely a different type of treatment for Parkinson's. And a little bit on essential tremor too, if anyone knows what that is. Thank you. So I always get nervous about talking about such a big topic to people who may not have heard of it before. So first of all, who has heard of DBS before? And who has heard of focused ultrasound before? Okay, great, awesome. Who has either of those things, or anyone? Oh, okay, awesome. If you wanted to share your story later, we would love to hear. But and one thing that I want to start with is first, what is Parkinson's? Because I did listen to some of the talks, but just so everyone's on the same page, not assuming anything. Parkinson's disease is very common after Alzheimer's disease. In America, it's second most common neurodegenerative condition. And 1% of patients or people over 60 years old do have this condition, and 4% over 80. So that's pretty high. As compared to another condition called essential tremor, which is shaking of the hands when you are using them rather than at rest. So just one classification there, because some of these treatments can treat both differently, and a lot of people with Parkinson's have essential tremor as well, so just something to keep in mind. So Parkinson's can be very expensive and disabling to patients and to the healthcare system. So many of my patients within the first few years of their diagnosis have to retire or can't function. And medications are more and more expensive nowadays, and not a lot of medication. You know, these new medications out there, they may help your symptoms for a few years, or they're very expensive and can't afford them anymore, so we go back to the generics. I'm finding that more and more, especially in January this year, it's been happening more for my patients. And of course, it's not easy to treat, right? So I'm sure some of you have had medications not working well after a few years, more higher doses, maybe more frequent doses. So things change, and sometimes over a year, quickly changes. So Dr. Buckingham mentioned, someone asked, Parkinson's disease specifically is the loss of a chemical name called dopamine. And it is specifically in the part of the brain called the basal ganglia. And this is important because this is where the surgeries are targeting. So important to know where in the brain we're looking at. And as you are well aware, the symptoms, rigidity, slowness, could be resting tremor, and then falls and balance, which is the most debilitating thing that I worry about. So back in the day, you know, when something was wrong, can we take it out? Can we just remove the part of the brain that's causing the problem? But it's not really great to remove a part of the brain that you need to move. So when we talk about lack of dopamine, dopamine controls the ability to initiate movements. So when you're going from sitting to standing, you're starting a new movement. When you're walking through a doorway, it's a change in your movement. And turning, those are all probably common problems, that we may have. And so dopamine also controls our ability to stop movement. So sometimes when you are walking really fast and you can't stop yourself, you can't really remove that. So we didn't really have good treatments until levodopa or Cinemet came out in the 1900s. And that's when we sort of were starting to do the research and developing Parkinson's in the animal model to try to figure out how to fix the issues. So in the 1800s, they did remove the brain, and that did not go well. So obviously people had a lot of trouble. And then in the 1940s, they developed something called a stereotactic head frame. And this was used for Parkinson's and Huntington's disease. And this is important because when you're trying to do surgery on someone, you want to make sure you're going exactly where you want to go. And, even millimeters can make a big difference. So when people found levodopa, specifically in the 1960s, no one cared about surgery anymore because levodopa was groundbreaking. I think some people know the movie Awakenings, so a little bit different concept, but those people didn't have Parkinson's disease, but they had a Parkinsonism. And the levodopa was incredible, cured their symptoms, basically. But as you know, side effects and wearing off takes time. So people didn't realize that levodopa has complications, doesn't last forever, isn't groundbreaking forever. So within 5 to 10 years, people started realizing that we need new treatments. So in 1986, they found that deep brain stimulation was actually a better option than what I call thalamotomy, which essentially is removing a part of the brain. So they found that actually stimulating the brain, so it is surgery, but you're not removing the part of the brain, you're just touching the surface of it and giving electrical currents to change the way the neurons are communicating with each other. And they found that it actually worked incredibly well. So after years of development, 1997 was when the FDA approved DBS for tremor in Parkinson's disease. So that's important to note because DBS can treat different things: tremor, slowness, stiffness, but it's good to know, what your symptoms are, what you're most bothered by, because if you aren't bothered by the things DBS helps, it might not be the best option for you. So if you're falling a lot and you have balance issues, we don't actually recommend DBS. So something to think about, but I'll talk about a little bit more. And then in 2002, FDA approved the DBS for other symptoms like rigidity and stiffness and dystonia, things like that. There was actually one study that found that DBS was even better than levodopa because it didn't have those complications like dyskinesia is wearing off, things like that. So for Parkinson's disease, in the basal ganglia, you have something called the globus pallidus internus, GPI. So when we talk about Parkinson's, usually we have these two targets in the brain, and patients aren't always involved in the decision making of which target. However, you want to make sure I want to treat my tremor or I want to treat my stiffness. I have balance issues. You should kind of know what you're most bothered by and make that known, because I'll explain some of my patients. They'll be on levodopa, but they don't notice a day-to-day difference or an hour-to-hour difference. So some people are very aware of on-off and some people aren't. And that's important to me because the deep brain stimulation will only do as much as levodopa at the minimum, but it will get rid of the side effects of the levodopa. So I like to make sure I know what levodopa is doing for you, and we'll talk about that a little bit here as well. So the other nucleus, which I personally like a little bit better, is the subthalamic nucleus, which is used for tremor in Parkinson's, so a rest tremor. And as you know, many of you might not have a tremor at all. So there's sort of two kinds of Parkinson's disease symptoms. One is a lot of tremor, and the other is very rigid. We call it the akinetic rigid subtype. So deep brain stimulation is also used in other conditions like OCD, chronic pain, depression. Some of these are clinical trials. Some of these are actually being used across the country already. So essentially, what it is electrodes. So if anyone is in physics here, you probably know, but the electrodes we call contacts, that is put into the brain and connected all the way down by what we call leads, wires, inside your skin. So you won't see really anything on the outside except at your scalp, which then gets covered up by your hair, into a battery, into your chest. So if any of you have a pacemaker over your heart, very similar kind of idea, similar kind of device. And I think you guys probably walked by the rep tables, so you can hold one of these in your hand just to get a sense of what we're talking about. So you can feel it over your skin, but it's not something that, you can move around or do. One thing that's to note that you can actually have a pacemaker and DBS at the same time. So, if you don't already have a pacemaker, we often choose to put it on the right side. So in case in the future, if you ever need one, you can still have both. So first things first, obviously, I hope all of you have a neurologist. That's step one, making sure you have the right diagnosis. So as I think we've already talked about, Dr. Lan had mentioned, atypical Parkinson's disease, there's Lewy body disease, there's other things, vascular Parkinsonism. So those do not work as well for DBS. So kind of making sure your neurologist is 100% sure that that's what you have. And it's not crazy to get a second opinion. I rarely, but I always will acknowledge when it's a tricky case, I'm not sure. I would say absolutely, like, I value this person's opinion, please go see them and come back. So it's not crazy to make sure that that is right for you, right diagnosis for you. And then the second part actually is a neuropsychologist who you met today. Good lineup of people, to not just to make sure that it's the right diagnosis, but to make sure that you have no cognitive issues already, because there is some research that shows that if you have a diagnosis of dementia, DBS is not the right option for you. As you might know, DBS is an elective procedure, so you and your healthcare team are deciding this. It's not mandatory that you have to have it. So if you do have dementia, it is sort of, we feel it's a contraindication. There is a category, which we talked about earlier, of some mild memory issues, short-term memory, that we feel new research is showing it is still safe to have surgery when you have some mild memory problems, but that's why it's important to tease out, is there something else going on? Is there Alzheimer's, or is there vascular dementia? Is there some other kind of memory problem going on? Or is this just related to old age and it's okay? So that's the second part. And then psychiatry kind of goes along with social work. Sorry, I'm very out of breath today. The other part would be to make sure that there aren't any underlying psychiatric illnesses like depression or anxiety, and if there are, that they're being treated and you feel comfortable, because there are some risks with DBS and depression and anxiety. For example, turning stimulation on in someone who might have bipolar disorder could result in worsening bipolar symptoms. So we want to make sure that your other diagnoses are treated well. And also, it's a big deal, right? I mean, it's a big surgery. You have to have caregivers. You have to have a lot of support, or one caregiver at least, have support and be able to come to numerous appointments before and after in the workup, make sure all your questions are answered. So I always like to involve our social worker and sort of our nursing team, because they are the go-tos to help us navigate that, because we might not always have the time to in between appointments to make sure your questions are answered. And then the other parts are physical therapy, speech therapy, people like that, to help us with determining your fall risk and making sure if you've all participated in LSVT, big and loud, those kind of programs are paramount. And then of course neurosurgery. I put them last because I like to, we work very closely with our neurosurgeon, as do most teams, but I like to make sure that you meet them well in advance of surgery, make sure you're comfortable with them, you have those surgical questions answered as well. And then at UConn, we have a at least monthly meeting with our whole team to discuss every patient. You know, we go through your MRI, we go through all the results of these testing and make sure everyone's on the same page that it's the right decision for them. So you might ask, you know, how would I even know that I'm a candidate? And when should I start thinking about it? When is it too late? So a good candidate is someone who has a good response to levodopa. So hopefully most of you are on levodopa, as it is one of the mainstay treatments, the best treatment. A reason you might not be on it is side effects or that you are early on in your Parkinson's, so you've elected not to, which is reasonable. And then, like I mentioned, levodopa targets the part of the brain called the basal ganglia. So levodopa is dopamine. So it's directly giving you back the dopamine that you've lost. So when it starts to give you the side effects, you can replace it with the stimulation of the surgery to help perform the same, you know, positive benefits without the negative side effects of the dyskinesias or the constipation, the fatigue, you know, those non-motor symptoms that you might have. A poor candidate would be someone who has a poor response to levodopa. So we have something in our office called an on-off test. So we actually bring you in, and if you're a candidate for a surgery or you're thinking about it, we bring you in at 8 a.m. off all medication. And we do a motor scale to see how bad your symptoms are. And we rate it, and it's a scale of 0 to 200, something you might remember doing in the office every time, but we take good care to make sure you're completely off and do that test. And then we give you your medications and we see what your symptoms are an hour later, 2 hours later. So you stay in the office and you wait. And that is called, you know, a Cinemet study or on-off testing, and it basically tells us how good your response to levodopa is. So if you might say, yeah, it helps my tremor, it helps this and that, but I like to know exactly, objectively, how much it does, because research has shown if you have at least a 35% improvement in that score, you are a good candidate for surgery. So that is something I like to have in my arsenal. Not like to, we must. And I've had patients who are 50, 60% improvement, which is incredible. They do really well. And I've had patients who are 20%, and I say, this is probably not a great surgery for you. And the tricky ones are ones who are about 33%, like right on the border. So those are kind of some numbers to think about. Another good candidate would be someone who has normal cognitive function. You know, you're still, you might be driving, working, still managing your finances, you know, the activities of daily living. That's not to say if you're not doing those things, you can't have surgery, but just to think about the neuropsych testing is important. Good candidate is someone who might have those side effects to levodopa, like dyskinesias, and then that on-off where the medication's working really good for 3 hours, and then I have 1 hour before the next med is due, and the meds don't work as well. So that's important to note. And then I already mentioned, but someone with atypical Parkinson's, like Lewy body disease or corticobasal degeneration, vascular Parkinsonism, drug-induced Parkinsonism might not be the best candidates. And what does it do? So how is it different than levodopa? Or medications? So the good parts of DBS are improvement in tremor and dystonia, and it reduces your medication load as well as lowers those side effects that we were talking about. So dizziness, fatigue, constipation. It does not do anything really for your speech or your swallowing. And studies have shown that it really does not help your walking. So if you are in a wheelchair and you think that surgery will help you walk again, I would not say that would be, you know, a good thing to pursue. There's other options. And then balance. So this is a little bit tricky because if you have, you know, if you've heard of dystonia, that's abnormal posturing. So you know, patients might have a tremor, but dystonia would be your hand is stuck in a fixed position or your leg is stuck in a fixed position. So if the dystonia is what's causing your walking problems or your balance problems, well, DBS can fix your dystonia. It will help your dystonia. So potentially it could help your balance indirectly that way. So in terms of the location, like I said, it's not necessarily for a patient to decide, but kind of thinking the research has shown that the DBS can lower the Cinemet dose. STN is good for tremor, I think we mentioned. The GPI target is helps improve dystonia and dyskinesias. So I think we have two of the reps or companies here today. So if you want to stop by, Medtronic and Abbott. There's also Boston Scientific. They all have their kind of pros and cons. Well, not cons. They all have their pros. Basically, the first that was around was Medtronic, so they're probably most known. But they have They all now have options for the rechargeable battery versus a battery that. So essentially, you can charge the battery by yourself at home, or if you don't want to think about it and you just want the doctor to tell you when to have it changed, that's fine too. So they all have that option. They all come with a device that you can control at home. So some patients want that control at home. Most of my patients don't. But if you want, the ability to have a phone in your pocket and know when to, if you need to have an MRI, you have to put an MRI mode. You want that capability, or your caregiver does. They all have that option. And so some are Android, some are Apple. So that might be something for you. And then the sizes are a little bit different too. So your surgeon will kind of show you the options and tell you the pros. And then Abbott is one that allows you to do remote programming, meaning you can adjust things at home. So if you really don't want to come to the office, or you go to Florida for half the year, like many of my patients do, like that is a good option as well. But so there's no research that shows one is better than the other. They all have great support and reps. Honestly, I feel it's the physician who sort of decides with you, and some patients are very specific on the size of the battery or things like that. But really, it's the physician and you kind of deciding that together. All right, the surgeon as well, I should say, not just me. So it's the surgical technique. What actually happens? So it's usually a two-part surgery. The first part is actually putting the contact in deep in the brain, like I mentioned, the basal ganglia here and the thalamus here. So STN, GPI, those are those two targets. So this is the outside of your brain, and the surgeon will put the lead in for the first surgery. And usually, most of the time, my patients, when I first bring this up, are very scared. It's brain surgery, but you have an option of doing it awake or asleep. And that sounds also a little bit crazy, but we actually prefer our patients to be awake because the ability to hear the brain be active and you move during the surgery and not be under anesthesia is paramount for having a good outcome. So we prefer the awake. And I know it sounds crazy, but you won't be awake when the surgery is actually occurring, meaning the lead is being put in, but we wake you up. So you're asleep for a little bit of it, and then we wake you up. Obviously, the surgeon's in the room. At UConn, we like our neurologists to be in the room as well, because you know us, you know our faces, we meet you before, we've known you for years. So we prefer to be there with you, so it's not as scary, especially when you're awake. It could be a daunting thing. And it is done, like we mentioned, that stereotactic head frame. So essentially, it's done with an MRI. So it's not like we're blindly going in to the brain. We can actually see exactly where. There's a lot of pre-planning for precise targets, coordinates, X, Y, Z. And we do usually put the battery in on a different occasion. Some people prefer just one surgery, getting over with, so we do in one day sometimes. And then afterwards, we usually let your brain rest. For, at UConn, we do 4 to 6 weeks of rest because you just had a pretty significant procedure. I will mention you usually can go home the next day unless there's, something that comes up, maybe the anesthesia. You need an extra time if blood thinners, there's some some reasons that you might stay a day longer. You do spend the night in the intensive care unit, so you get hourly checks. And so we don't actually turn on the stimulation until a month after the surgery. So again, like I said, mostly for the brain to rest. And there's different settings that we can adjust to help with your tremor. So a lot of people, like I said, prefer the physician to do everything, and you see the neurologist in follow-up once a month, and then after that every 3 months. But it's usually not something patients want to fine-tune on their own at home. They prefer the neurologist to do so. It is MRI compatible, which, you know, obviously you think, oh, metal in my body, can I have an MRI? But it is MRI compatible. We just like to change the setting when you go for the MRI, so it doesn't interfere. So why DBS? Why not meds? So we already talked about the fact that DBS helps with the same kind of symptoms as your medication. However, it doesn't have the same kind of side effects and potentially lasts longer. So for example, with meds, we have to keep increasing their meds over year after year, but with DBS, we can increase the stimulation instead. So there's a long-term kind of gain there. It's still not a cure. So unfortunately, the disease will still progress. So we'll still need to adjust the stimulation over time. That's not a bad thing. That's just what would have happened anyway. And we won't really help you with your walking or your balance, more for tremor and getting decreased on the dyskinesias, decrease your medications. So I don't promise my patients 0 meds, but you know, the research shows 30 to 50% reduction in medication, usually levodopa, and that's the one that has the most side effects. So that's why it is a pro there. So quickly on adaptive, I know a lot of people had questions on this, but essentially the researchers found that different symptoms produce different electrical currents in our brain, and we can hear those currents, we can record those currents, and then we can adjust in real time. So before, we would just have a stimulation on at 2 all day long, and that was it, and no changes. So if your symptoms got worse, DBS doesn't care. It would be just going on. But now we're able to adjust. So if you have a little bit more tremor, we can record it, we can hear it, and it will adjust the simulation. You don't have to come into the office to make that change. So still a lot of tweaking to be done. It's not a perfect science, but the research shows, you know, that actually it can save battery life, so you don't have to replace it as often, and potentially can improve your symptoms. Okay, I just want to be cognizant of the time. We're going to skip the essential tremor talk, and then just quickly, what is focused ultrasound? So it was anyone who needs to leave, please do. Focused ultrasound is FDA approved for both Parkinson's and essential tremor. Essentially, the big difference is huge. So it's not a small difference. So it actually is an outpatient procedure. There's no overnight stay. And really, it's just for tremor. That's all it does. So if you don't have a tremor, ignore me. But it is now kind of archaically going back to the 70s and 60s, where it burns a hole where we are talking about. So it burns a hole where the tremor is actually occurring and starting from. So it helps your tremor. It's a one-time surgery, and the results are immediate. However, for Parkinson's, does not help your stiffness, does not help your slowness, does not help your walking, nothing else. So very subset population. I prefer focused ultrasound for my tremor patients and my essential tremor patients. If any of you have that, I'm happy to talk further about it. But people, you know, it's all over the news, it's all over the media. So I definitely talk to people about it. It's also an alternative if someone doesn't qualify for DBS, but they have a debilitating tremor. Say you can't get surgery because you don't want to be awake for the surgery, or you have a lot of medical issues. That would be an option to do the focused ultrasound instead to help your tremor, but not the other symptoms. So, so that was my quick talk. I have plenty more to talk about if you have any questions. But UConn, I know we're far away from you guys, but we have a lot of events, and we're having a comedy event, a comedy hour coming up in March. So if anyone's interested, please email us. We have a whole team. Sheila, my nurse navigator, is here with us, and we have a great neurosurgeon, great neuropsychologist, and plenty of other movement docs. So we'd love to help you in your process, whatever that is. Thank you for having us.
Thank you so much, Dr. Selvadurai. Does anybody have any questions for her?
Yes, thank you. Closer. Hello. Testing. Um, we were concerned if we had AFib and on blood thinners, is focused ultrasound still an option?
Focused ultrasound still an option. So yes,
Okay.
yes, both DBS and focused ultrasound still an option. You might have to hold the medication for a certain number of days before and after. However, that would be to be asked of your cardiologist to make sure that they're safe to do that. Similarly with a pacemaker, because the focused ultrasound is in with an MRI, you have to hold, and you might have to stop the pacemaker for that. So that is
Okay, there's no
okay,
pacemaker
good,
involved.
good. Yep.
I know this is probably, does it interfere? Like, I know if he had the Watchman in, which he does not, that it would cause an issue with the AED. Would the DBS also have that same situation?
So I believe an AED and pacemaker are similar technology, so it would be probably fine. A Watchman, I don't think is electronic. I think, isn't it just they fix the problem for the AFib, and then you don't have to take the anticoagulation anymore.
Yeah, I think
Yeah.
it's some kind of device. I don't know.
Oh, it's a
But
device. Okay.
I don't know.
Should be
we're
okay.
trying to
Yeah.
figure things out right now.
Okay. Yeah.
But
It should be okay. The newer technologies, like everybody knows that you need MRIs in your life. So everything is pretty MRI safe, but I'm pretty sure, and we can actually ask they left, but they're outside. We can ask the reps outside
Okay.
if that would be okay. Yeah.
okay, thank you.
Comment, Craig.
Those side effects you listed for focused ultrasound, how permanent or temporary are those?
Yes. So the most common side effects are balance and the speech issues, and about 10% of patients have them. So it's not insignificant, but so both. So sometimes it can be permanent. So about, I don't know the exact number of permanent, but because it was only approved in 2018, we're really seeing those patients now after 3 to 5 years. And I didn't mention the tremor can come back, so you might need another focused ultrasound, procedure, 6 months, 1 year, that frequency. Yeah.
Any other questions? All right. Thank you so much, Dr. Selvadurai.
Thank you.
Thank you so much for everybody for coming. Just to recap, we are RVNAhealth. We have been around since 1914. We are at 27 Governor Street, but we treat in-home, out of the home, hospice, palliative, home health aides, all the above. So if you need any information, I will give you my card. And I'm really grateful for you all for attending. Thank you.